this kind of fracture, there may be some blister or all around the ankle joint. So it is very important to very much closely observe the whole skin around the ankle joint. So initial part is reduce the ankle joint with some external fixator and do the CT scan, and then properly plan to what kind of fixation we should go for.
Yeah. So a lot of good points. So probably these kind of X-rays should not be taken. Yeah, it's rather reducing under analgesia and put it in a splint before doing X-rays, because this is still badly dislocated, no protection, and you're absolutely right. This is not so good for the skin, and one would expect, particularly on the medial side. Do you see my arrow?
Yeah.
Yes.
Yeah. So particularly here on the medial side, this is typically where the skin is tethered and where there is problems. And as you have righteously noted, there seems to be a posterior fragment, medial lateral fragment, so quite a bad injury. So this has been done. The reduction was done in a closed manner in the ER. The patient was put in a cast, and this is the CT after reduction. So it gives us a bit more of an idea what the problem is. And now the question is, what is the plan?
Abhijit, do you carry on? Would you like to carry on, or somebody else will discuss on it? Abhijit, you started, you carry on in this case.
Yeah, so definitely, so we need to fix the whole thing. There is a fragment posteriorly, a weak chunk.
Yeah.
So we can address this kind of fracture with two separate incision, definitely. So
before that, can you talk about the mechanism of injury of particular type of what kind of injury according to log Hansen classification?
Yeah, it is something like
it looks a lot like an abduction mechanism. If you see that. Yeah.
Adduction.
So the whole talus pushes the fibula. There's an indirect fracture, not so much the typical spiral fracture of external rotation injuries. So the talus pushes the fibula. The injury starts probably here at the median malleolus, and typically this results in irregular fracture patterns, as you can see here, not a clear spiral fracture. So I would say it's an abduction, pronation abduction injury.
Yeah.
Yeah. So two approaches. Which approaches would you choose for that kind of fracture?
One is posterolaterals. You can go through the posterolateral and fix the both lateral malleolus as well as the posterior part of the.
And then I guess a medial approach for the medial malleolus.
Yeah.
This sounds like a very good plan. What would your indications be to fix the posterior malleolus? I agree. Yeah.
Except the ones which are extensive, okay. I think all the posterior.
Sorry, I didn't really understand you.
Except the one which are extra incisional, like Bartoniak RAMMELT type 1. I think the rest needs to be fixed.
Yeah. So we would also at type 2, we would probably not fix if it's completely undisplaced. But this one is definitely displaced, as you can see here. And as you can see here, it follows the fibula. So the incisura is damaged. The incisura is not there. There are intercalary fragments. So these are all points where I would go forward and be relatively aggressive to fix that fragment. So I absolutely agree. So this was, yeah. Someone is talking in the background. So this is what has been done. Obviously, a lateral and a medial approach. My question is, everybody happy with that? So obviously the posterolatus was not fixed. But what do you think about the reduction?
Not good. Not acceptable.
Not so good. What?
Acceptable.
It
is acceptable.
Acceptable. Yeah.
Yeah.
Oh, the syndesmosis is still open.
Yeah, it seems here.
One thing, you can ignore the third mandibular, as because it is less than 1/3, and the stepping of the articular surface is less than 2 millimeters. And what about the syndesmosis? That is the lateral malleus and the medial malleus. Fibula and the tibia. I think that is also disrupt. But the screw does not extend into the tibia.
So what can be seen? It seems the posterior malleolus is
a
bit. Yeah.
What else?
We have the post-operative AP view as well. You are showing the lateral view, the post-operative AP view as well.
Can you see? Do you see the AP view?
And the reduction is okay. You can ignore the third malleolus. But what about the syndesmosis? That is the tibia and the fibula. I think that is also disrupted. And this injury is the ankle injury is due to the abduction force and rotational force. Abduction and rotation. And at the same time, it is the pronated force.
So it seems the posterior malleolus at least looks a bit better than before, even though it was not manipulated directly. And the big question is, what about that fragment? Is it really where it belongs? And how about the syndesmosis? And what is always critical, if the tibia does not align with the talus, yeah, then you should always suspect that something is not okay. And remember, this is a young patient, 38 years old, very active. So how can you tell what is wrong, if something is wrong?
Because in the AP view, anteroposterior view of the ankle, the overlapping of the fibular shadow and the tibial shadow is more than less than 2 millimeters possibly. And at the same time, in lateral view, it is not, the foot is not in the equinus position. So how you can manage the third malleolus without putting the foot in the not in equinus position, without fixing it?
Yeah, so I guess it might have moved a bit, but it was not manipulated. So of course, when manipulating the fibula, the posterior malleolus is attached to it via the posterior syndesmotic ligament, so it can move a bit.
આનાથી કર્યું posterior malleolus ખાલી થઈ ગયું એ તો ઠીક છે અને આનાથી ફિક્સ કર્યું.
So would you say it is acceptable? We can leave it like this, or would you like to know in this type of patient with this type of reduction, what is really going on?
I just want to ask any symptom of the patient right now, any problem right now with the patient, any complaints?
No, she's 2 days after surgery. The wounds are fine, so there's no complaints from the patient.
I think in my setting, if I have done the same thing and I'll wait for the time to come when the patient complains for some symptoms first. If at all some symptoms arise, then I'll go for redo. Otherwise, I will accept this.
Okay.
Sir, sir, the syndesmosis is open. The posterior malleolus has not been fixed, sir. It is there is no posterior plate that has been applied. So this is going to fail in time the patient starts weight bearing. This is going to fail, sir.
So you would go forward and do something now, not wait for it to heal. And I would go in the same direction, because now the patient is 2 days after surgery. Nothing has healed yet. So if you want to go for an early correction, this would be a good timing. If you wait for it to heal, and let's assume the syndesmosis is not reduced ideally, then, and the posterior is not in an ideal position, then if you come later, you would have to do an osteotomy, which is more complicated. And if the syndesmotic ligaments do not heal in a proper position, and if the syndesmotic ligaments do not heal in a proper position, then you cannot suture them back. So then you have to go for something else, some suture button techniques, some ligamentoplasty. So I would say it is easier, if something is wrong, to do it as early as possible. The question is, how do you find out what is really going on? So how about doing another CT scan?
Yes.
Yeah.
Yes. Yes.
So this is the post-op CT scan.
Yes. So there is a big chunk posteriorly already.
So it sits a bit better than before, but it has no contact. And as you can see here, it is still displaced. It's better than before. So with manipulating the fibula, it is better, but it's still displaced. And what is interesting, you can see here. So the fibula is has an internal rotation, yeah, and it takes this posterior fragment with it. And then there seems to be another problem here, which has not been paid attention to. Yeah, so there seems to be an anterior syndesmotic avulsion too of the fibula, so the so-called Wagstaff fragment. So the syndesmosis is still unstable, and the bony fragments are not in place. The posterior fragment is not in place, and the anterior fragment is not in place either. So I would say, even though it's not a big deformity, it's maybe about 2 millimeters, so it may be just the borderline. If you let it heal like this, then you will have some incongruity of the ankle mortise. And again, here you can see the talus is still shifting a bit, and this is a very, very important line that you also can see on the X-ray. So if this lateral aspect of the tibia does not align with the talus, then there's some problem at the level of the syndesmosis, of course, assuming that the talus is in a proper position. So what now? I think we have to come back to Dr. Bandopachai's suggestion and coming in directly from the back to bring this back.
আমি এখন কনফারেন্সে আছি পরে কথা বলবো
I did not understand that.
Yeah, actually, we have to proceed from the posterolateral aspect of the injury so that we can hold the posterior fragment as well as the lateral malleolus.
Yeah.
And also we can address the syndesmotic as well.
Yeah. So been done, and it was still within 1 week. So the patient was first treated at another hospital, and she got herself transferred to our hospital. So the posterior fragment is fixed. In this case, it is fixed with screws. And the anterior fragment has also been fixed. The anterior tibial fragment with a small anterolateral approach with a 2.7 millimeters, so with a lesser screw and an additional suture anchor. And now it is just like holding the reins on the syndesmosis. So both the posterior syndesmosis and the anterior syndesmosis are fixed bone to bone. And this gives more stability than, and is a direct fixation. So it is better than, for instance, a syndesmotic screw or a tightrope. And as you can see here, when placing the hook test, it is stable. So bone-to-bone fixation is a direct fixation of the syndesmosis, and both the anterior and the posterior syndesmosis have been fixed. Yeah, the Wagstaff fragment have been fixed, and the posterior fragment, and yeah, yeah, with the posterolateral approach. And so this is a direct and more stable fixation than, for instance, leaving it as is and just putting a syndesmotic screw or something like that, which is always an indirect fixation. But now we want to know if we did it right. So we check it with the CT, and now you can see now the gap is gone. The posterior fragment is where it belongs. The rotation is corrected. The anterior fragment is safely where it belongs. And the incisura is now nicely restored. So the rotation of the fibula is now centered again into the incisura. So, and this patient doesn't need a syndesmotic screw, and which would be not so easy to get through here, but would be doable. And now you can see that in all the projections, she has a good ankle mortise, and which I think is important for a young patient. So the bottom line is we have to address those syndesmotic avulsions. So the posterior malleolus has long been termed like this because it's important to fix it because it holds the posterior syndesmosis. But the same is true for the anterior syndesmosis. Either the bigger chunks are coming from the tibia, the so-called tillot chaput fragments, but like in our case, the Wagstaff fragment, which we would say it's the equivalent of the anterior malleolus. So it's like it's like a circle that you have to close. And indeed, we have put this forward in the Aero manual for the first time. And we now have published the first series of these patients where we really went and fixed all the 4 malleoli. And in almost all of these cases, we did not need a separate syndesmotic fixation with a syndesmotic screw or tightrope or whatever. So this also spares us the whole discussion how to place it. And as everybody knows, there's also a chance to displace the fracture when putting in a screw. So these are the messages from this case. If in doubt, we have a very low threshold on doing a CT scan, because you cannot judge the size and the position of that fragment, particularly of the posterior fragment. You cannot see if there is impaction. You cannot see if there are small intercalary fragments. But this is important because this guides you to your decision if to fix it or not. So just the size of the fragment, like 1/3 or 1/4, it is also an important factor, but it's not the only one. It's one of many factors. And all 4 malleoli should be addressed because both the anterior and the posterior fragments of the tibia or of the fibula hang on to the syndesmosis. And if you stabilize them, you restore adequate tension of the syndesmosis and you restore bone-to-bone fixation, which is more stable than any indirect fixation with a syndesmotic screw, for instance. And we know that 1 or 2 millimeter already shift the load in the ankle joint. So it's a weight-bearing joint. Most of the ankle arthritis that we see are post-traumatic. 70–80% are post-traumatic cases. So we really should go for an anatomic reduction. And when we fix those syndesmotic avulsions, we do not only recreate stability, we also recreate the incisura. And only then the fibula knows where to go. And so it helps also with fibular reduction. Yeah, so these are I think the messages from this first case. And you can find these and other cases in the AO book, which was also put together by a famous doctor from India. So this was the first case. Do you have questions?
Yeah, can I ask a question?
Of course.
Now, your message is very clear. I think a very clear and sound message. I'd like to ask, what's your, how do you position your patient for this kind of fixation and what is the sequence of it?
Very good question. So the patient is in a prone position, which already, if you have posterior instability, already helps with the reduction. And I almost always start with the posterior malleolus because with fixing this, I recreate the incisura. And then if you turn to the fibula, then you see it is almost reduced. Not perfectly, but it also helps with fibular reduction. And also, if you go posterior, then, and you don't have the fibular plate on, then you can see the reduction. So if there's no screws in the medial malleolus, if there's no plate on lateral malleolus, then you can really judge your reduction nicely. Because once you have brought back that fragment, you cannot look directly into the joint from behind. If you open it, you can see the joint, you can fix small intercalary fragments, but once you put it back, you do not see the joint. So you have to rely on a good lateral fluoroscopy. And if you have screws in the medial malleolus or a big plate on the lateral, you don't see it. So this is my second reason. I start with the posterior malleolus, and this really recreates already some stability and helps with fibular reduction. Then from the posterior malleolus, I go to the fibula, and as Dr. Banjopatai also stated, you can fix the fibula very nicely from behind. Same approach, same posterolateral approach, gives more stability because you have an anti-glide plate instead of a lateral plate. Sometimes it might be wise to put a lateral plate depending on the type of deformity of the fibula, but in most of the time, it is good to have a posterior plate. And then number 3 is the medial malleolus, and which you can also fix with the patient prone. It's the same approach as with the patient supine. And then I just have an assistant bend the knee, and then do a very small approach on the front of the fibula to fix that tiny fragment, either Wechsler fragment, or sometimes it's a Chapuis fragment, and it's here, yeah. And you do this in the end, and it's just helping with stability of that fragment and of the syndesmosis. So this would be my order.
Great. Thank you. Thank you. Any other question from the viewers?